what our hope is for today is to really have an open conversation with all of you around some of the optimism and challenges and questions you have about this emerging area of innovation, food prescribing. So I'm going to be hosting today. If I'm a new face for all of you, I'm Jen Reynolds. I'm one of the co-executive directors of Nourish, and joined today by Meyer and Rachel, and our two interpreters. And if you're new to the call and wondering about how the interpretation works, you can put in some questions into the chat. It's pretty intuitive, but you just need to choose your language of choice at the bottom, English or French, and then you should be able to hear the simultaneous interpretation.
Mais bon, il s'agit tout simplement de cliquer sur interprétation et choisir le français. Donc, aujourd'hui,
and with a kind of going at a higher level and learning from the exciting work and frame of social prescribing. And I'm not sure, I can't see if Kate has joined us. So Kate Mulligan is, maybe I'll give her intro while we're waiting for her to show up. She's just coming from a course that she's teaching. She is an assistant professor in social and behavioral health sciences at the Dalai Lama School of Public Health at the University of Toronto. And she is also the senior director of the Center for Canadian Institute for Social Prescribing. And her research and area of practice and interest is really at that intersection of how health and well-being can be really informed and driven by collective impact and community health. And here she is. Welcome, Kate. Just seeing you there. Hi. I was just giving your bio because I don't know if you have the same experience as me. It's a bit humiliating to hear your bio being read out. So I was trying to save you from that.
Thank you very much. And I'm sorry for being late. I rushed right in from my class.
Yeah. Thank you. No, this is great. We appreciate you fitting it in, and we're really excited to be having this conversation. So I was just sort of stretching.
So I'll close my ears to any other parts of the introduction.
No, all good. No, I was just framing up today. That we were hoping to have a conversation as several of the teams in the cohort are experimenting with food prescribing, implementing different ways to be delivering that and learning as they're doing around, how to organize the food side, how to organize the prescribing side, what is the screening aspect, and then starting to look at how they're going to evaluate and understand impact. And as we had an initial chat we've been speaking with you over the past few years, Kate, it just felt like a great opportunity to bring you into this conversation with our cohort around your expertise and understanding and learning about where social prescribing is at, where it's headed. And our plan for today is just to give you the floor for about 15-20 minutes. Thought we could take a few questions just about what the center is doing and social prescribing writ large, and then we could dive into an open conversation driven by questions that everyone on the cohort is experiencing around how to do social prescribing and specifically food prescribing well, and what it could look like collaboratively, where we're headed as we seek information, ideas, inspiration about how we can do this bigger and better at scale. So any questions there? So one thing I just want to double check, Kate, we're using interpretation for this to facilitate. So are you aware of how to do that? So at the bottom, there's a little globe.
I'm all set. I'm good.
Yep. Okay, perfect. Okay, so any questions, put them in the chat. Otherwise, I'll turn it over to you, and you can.
Okay, thanks. And I can't see that many people. I don't know if that's just because many have their cameras off, or
I'm not sure. Yeah. Do you want to have a sense from folks who are there?
Well, there we go. I see a few more people. Okay. Well, yeah, it's nice to be able to see you, but feel free to keep your cameras off if you're more comfortable that way. But that's okay. If you're comfortable putting it on, even if it's just while you're speaking or raising a question or a comment, that would be great. Because I'd like to meet you and learn more about what you're doing. So listen, thanks so much for having me with you today. I am thrilled to be here. Thrilled that many of you are thinking about social prescribing and food prescribing as part of what you're doing. I am going to give a fairly simple overview of what social prescribing is and what we're trying to do through the Canadian Institute for Social Prescribing. So if that's too simple for where you are, like stop me, interrupt me, and get me up to your speed in terms of, what are the challenges that you're facing in trying to implement this in practice? What are the technical or political or communications or any kind of challenges that you might be facing or questions that you have. But some of you, I understand, might be brand new to this, so I wanted to start with that in mind and just give a very brief overview about what social prescribing is. So I'm just going to pull up my screen so you can see a couple of slides that introduce that conversation. Here we go. You can see that okay?
Yeah,
Great.
perfect.
Okay.
Yeah.
So, and I've added my email address on here if you want to have a conversation after or follow up with me. I'm kate.mulligan@utoronto.ca. And I use the lovely graphic from Nourish around food prescribing. So social prescribing, very briefly, is a pathway that connects healthcare services and community and social services, formal or informal. So one example of a way a social prescribing pathway might work is that a person, right, that might be called a patient or a client or a participant, goes to see their healthcare provider. In this particular example from the World Health Organization, it's a primary healthcare provider, but it doesn't have to be. It can be in hospital, it could be in long-term care, it could be in a range of different settings, and it could be a range of different types of people working in healthcare. So a nurse practitioner, a social worker, a health promoter, and so on. That person can use formal and informal assessments to get an understanding of a person's strengths and needs when it comes to social prescribing. In other words, they have, perhaps in addition to their clinical needs, they have a need rooted in one of their social determinants of health. It might be access to food. It might be access to housing. It might be social connectedness and the need to be around other people, or a need to connect to culture, arts, land, right? Different components of their well-being. But generally speaking, it's something that's beyond the clinical scope or capacity of that primary healthcare provider to provide, or it's beyond the time that they have. But they know that there's an issue and they don't need to even know really that much about it, but that there's something that's beyond their clinical scope. That person then refers that patient or participant to what's sometimes called a link worker or a well-being coordinator or a community connector who has more time, who really spends a lot of time with that person to develop a personalized plan for what to do, how to address those needs rooted in their social determinants of health. And here it's really important that that person is very much in the driver's seat, that the person gets to make decisions about what their needs are, what their strengths are. And then together they help shift the conversation away from what's the matter with you to what matters to you. And it's in that personalized conversation that you really focus on that person's self-determination, which has a few different components. One is a sense of belonging in the community. One is a sense of self-efficacy or ability to kind of have an impact in our own lives. One is a sense of purpose and meaning in the work that we're doing and in our daily lives. And one is a sense of beneficence, which is a long word that just means it feels really good when we give back and we share and do something for other people. So when we do that, we see big gains in our well-being. When we see ourselves moving from thinking of ourselves as someone with problems and challenges and illnesses to somebody who has something to offer, something to give, that's a really important component of the work of social prescribing. So they have this long conversation, maybe a few conversations, and then there's a referral to those appropriate community-based services. And so in your cases, it might be referral to a prescription for healthy food or to participation in food programming, cooking classes, agriculture, food growing, gardening, you name it, different things that have to do with the culture of food, the experience of food growing, the experience of eating, and having access to healthy foods. And then, they've got on here counsels the patient using behavior change techniques. I would argue that's not critical to the work of social prescribing. We don't necessarily need to change people. We need to make sure that their strengths are being used and their needs are being met. in a way that's meaningful to them. And in that work, we're also connecting at a systems level. So we're connecting to the community and voluntary sector and strengthening community connections at the same time, building partnerships between health and community services. You all know this really well because this is what you're doing in your projects, building new networks and new connections. And then, further expanding what we think of when we think of what's a health system, not just a healthcare system. And what are all these supports and services that have always improved people's health and well-being, but have never been resourced in a way that recognizes that, or measured and evaluated in a way that shows what those health outcome benefits are, health experience benefits, impacts on the health system. Like we all know, if we took away good food work, there would be an immediate impact on health systems. People would be sicker, right? People would be coming in for more acute needs. But we need to shift that focus away from just acute healthcare and share more resources to prevention, to community management, and to the capacities we all have to take care of our health and to help our community members take care of one another's health. So here's where, you go and you do the activities, and it could be short-term or long-term. And then there's a bit of a pathway, a feedback loop between the prescription and the follow-up. So you check in again with the link worker. They make sure that things are going the way that you want them to be going, that you feel included, that you're, they check on whether it's had an impact on your health or had an impact on your use of health services. And likewise, that circle includes the healthcare provider. So we can track what happens in the electronic medical record, for example, and see if this is changing your health outcomes and your self-reported health outcomes, which matter a lot, and your experiences, and as I said, your use of health services. So that's basically the pathway for how social prescribing can work. But as I mentioned, it's not just an individual pathway, it's a systems intervention that builds connections between institutions and organizations in different sectors and at different scales. So at the Canadian Institute for Social Prescribing, these are just some of the partners who are coming together to do a collective impact project to co-design what we think social prescribing could be and could look like all across Canada. So trying to bring together partners from healthcare, from communities facing very specific barriers to health equity and to access to healthcare and social determinants of health, and other community organizations. So we can, part of the reason is to recognize, again, that the community level contributions, they're not just a series of disconnected small projects. This is actually a sector. And this sector matters. And the more we can demonstrate what we do and how we do it and what the impacts are on people, the better we can help tell that story and also improve and learn. Here it is. I already talked about this part about self-determination, so I won't get into it too much again on this slide. But again, you want to feel you can make your own decisions, have an impact in your life, that you belong, and not just in the sense of having social connections, although there's good research that shows having a couple of social connections can help you to thrive even when you're facing social and medical challenges. But also in the sense that what matters to you matters to other people too, and is being prioritized and is being heard. So if you feel that your life experience matters, because there are people working on this food prescribing project that notice you, care about you, listen to your voice, and that maybe you're able to give back as a volunteer, or even as, just by sharing your voice and your experience to the program, that's belonging, right? That we all really include one another in that sort of shared prioritization. And then there's that part about giving back and volunteering, which we know is, we sometimes call it the giver's glow, that it just feels good. And that, I should say, is also relevant and important for everybody, not just the participant. So there's good research that shows healthcare providers can stave off burnout by participating in this. It's more fun to be at work. There's more of a sense of purpose and belonging. Finally, able to take care of some of those people that were keeping these providers up at night because they weren't really able to provide the most appropriate care or in the right way. They know those people are being taken care of. The reason they went into healthcare was to help people, and maybe now they're better able to help people and so on. So this helps many people who are involved in the process, likewise family caregivers and others and so on, and community members. So, and this also works at multiple scales. So the individual who's participating, but we know that community and sort of political self-determination is also really important, particularly for Indigenous communities, where this is really at the foreground of health and well-being and creating sustainable futures. but also for other communities where self-determination is really important in being able to make those decisions and create that sense of belonging for example, new immigrant communities or Black communities or older adults and so on. So very quickly, I just wanted to share a few examples, and you'll have your own examples that look different, of ways that different organizations and collaboratives are trying to do food prescribing in particular. And this is one where, you know, governments, I think, and health systems are very interested, and it's easier in some ways for them to wrap their heads around why this might have a health benefit because of the clear relationship between healthy eating and food security in some cases, and well-being and the use of health services. So the Houston Food Bank, and I'll share these slides afterwards so you can follow the links and check these out for yourselves. The Houston Food Bank, for example, screens people through a healthcare partner through a program called Stay in Community Health Program. They issue a food prescription card, and then that can be used at a specific market called the Food for Change market. Right, so that's one way that we can do social prescribing. It's sort of a voucher type system, and you can see, and maybe folks from Guelph are even here on the call today. So Guelph and the Seed do something a little bit similar. They offer vouchers to people to come to good food markets or to access, to access healthy food that's grown in and by and for the community. And they think about that as part of their more holistic approach to health and well-being. And there's also access to other food-related programming. Another one that was funded through Nourish was the project run by Food Share and University Health Network. So that was for a good food box to actually be delivered to the homes of people who were screened as having a food-related health need. And I believe that one was a pilot that didn't continue after its initial run, but we have some learnings from that one as well. So you can click on that one and learn about it. And then there's a disease-specific one. So on the south side of Chicago, there's an initiative called Improving Diabetes Care on the south side, where they issue a rebate. So you get sort of a coupon to go and use it in the grocery store for a broad list of different choices of what's on the list as a diabetes-friendly foods, and those ones you get a discount on for participating, regular commercial grocery and pharmacy stores. So like Walgreens on the list here. So this is another one that, for example, maximizes choice for people and participants, allows them to continue their normal food shopping routines, but maybe provides a little bit of a nudge or incentive toward buying diabetes-friendly foods and supports the ability to afford those foods. And then oftentimes that food prescribing work takes place in the context of broader or multiple interventions. So this is just an example from a group called Building a Healthier Pasadena that included food prescribing within a series of initiatives that included production, distribution, and consumption initiatives. So they had a policy developed around this. They had what they called food scholarships. They had, changes in the distribution and support. So this was happening in the context of broader initiatives. And sometimes that can be important for people who are interested in, well, it depends on the outcomes that people are most interested in a given community. If the outcome is around food security, you may be needing to do this more comprehensive approach. If the outcome is more specifically about changes in diabetes status for a small limited population, maybe you don't. Maybe you need something that's much more targeted, but maybe much more long-term, where you see the healthy food as something that you could use in place of pharmaceutical medication. And that long-term access to a diabetes-friendly diet could take the place of or be thought of in the same way as a pharmaceutical intervention or another clinical intervention. So you need to think carefully about what are the outcomes that matter to you, to the people participating in the program, to decision makers, to others in the health system, and so on. So in program planning and design, those outcomes really matter because it'll affect how you design your program and how you evaluate it and how you tell the story. So some of the different kinds of things that we want to learn these are the reasons why building an evaluation, even a very simple evaluation with a few questions about how people are doing in the program, it's really important so we can improve the programs, but also share our knowledge and share the good work that you're doing. So, is there a change in your self-reported or objectively reported healthcare experiences or food experiences? Is there a change in your healthcare or food outcomes? Right, so those are different. How did you access food? Is it different from the way that you used to? How did you do healthcare? Has it changed in some way as a result of this food prescribing program that we're doing? You want to know what would improve the design or implementation from the different kinds of perspectives of people involved with it. Maybe you want to know whether there have been unexpected challenges and how you might mitigate those going forward. And then you really do want to think about program sustainability. What can we learn about what are the costs of the program and who bears those costs? And maybe, did we shift the costs from one place to another? In other words, we're less so paying for pharmaceuticals or hospital stays and more paying for food budgets. And so, that's a challenging one for governments because they might be accommodated within different line ministries who don't feel a sense of shared accountability. But those are the kinds of things we want to learn so that we can explain if there's an overall cost saving, for example, in doing this work by shifting budgets to things that we think are more appropriate, potentially more affordable, or spread out across different ministries and those kinds of things. So those are some of the types of questions. You'll have your own, obviously, your own program evaluation questions that matter to you. But I just wanted to tweak some of those that matter when we think about also aggregating all of the different projects that people do, so that we at the Canadian Institute for Social Prescribing, where I work, can tell the story on a big scale about what all the small intervention projects add up to. And so that's what I'll end with, is just telling you a little bit about who we are. We are an institute funded by the Public Health Agency of Canada. We do that collective impact work that I mentioned. And what we're really trying to do is help to scale and spread social prescribing across Canada. And we would include food prescribing in that, as well as many other types of social prescribing. And food prescribing might be inclusive of other approaches to social prescribing as well. For example, food work can also be community building work and social connectedness work and outdoor nature work and so on. So we are bringing together folks like you, people who are doing innovative and great practices. We want to surface them and help you tell your stories. We want to help you connect to funders and to decision makers. And we want to help you grow the work and people to learn from you and from what you're doing. Likewise, if you're just at the beginning of your journey or you haven't thought about food prescribing, we want to be there for you. So over time, we are developing curriculum for post-secondary and workforce development. We are developing networks and communities of interest and communities of practice for clinicians, researchers, implementers, participants, and so on. Importantly, we're really trying to keep a few key principles at the forefront, because there is that risk that the term social prescribing or some of the work could be co-opted by mainstream old-fashioned ways of doing things that don't really change our practices. So we want to make sure that as this practice grows, and the more people hear about it, the more they like it, so it is growing, that we prioritize health equity, that we're reducing gaps in inequities, and that we're putting community leadership and the leadership of participants, of communities facing barriers to health and well-being, and of the community sector and community organizations really at the forefront of the conversation. And that we do this in a way that doesn't compete with one another.
Qui soit priorisé. Et donc, on veut que ce soit une approche collaboratrice aussi.
It's hard. We tend to compete for funding. We don't have stable resourcing. We don't know where our next check is coming from. We don't know how long we can be offering programs, all that stuff. So we're trying to make sure that we continue to put collaboration and sharing at the forefront of that work. And we're connected into a global network, the Global Social Prescribing Alliance, so we can continue learning from good practices in other countries and share what we know with other people who are doing the work around the world. And we know that it's happening in at least 20 countries globally. There's increasing interest by the World Health Organization and other global players. So I think it's an important way to think about framing some of the work that you do, so that you, ideally, you can see yourself in this movement. And when funding opportunities arise around this, that you're ready to take advantage of those and to help keep pushing the policy and practice forward when it comes to context of food prescribing, in the context of social prescribing. And that's all I wanted to share. And I do have, I'm hoping I can learn more about what you're doing and have a conversation with you about where this kind of work might take you and where you might see yourselves in it.
Amazing, Kate. Thank you for that intro. And probably our minds are all firing. So I wanted to, for the introverts like me, maybe start to think of your question, to be brave, to bring your voice in. But there is a great question, maybe to just sort of round out and give a bit more detail from Roxanne in the chat, Kate, of just some from the early work that you've been doing on social prescribing. What have been some of these results for individuals and families and outcomes?
Yeah,
because I think that's really a compelling story that's led to the creation of SIS. So
yeah, so the results are really promising, but it is a really new practice. So it's ongoing. We already know there's great evidence for the kinds of interventions that people are referred to. So, we already know there's good evidence that being in nature is healthy. Access to healthy food and healthy eating is healthy, right? Physical activity, healthy, right? So, we're going to these sort of very evidence-supported interventions. So that part's not in question. The part that we're learning about is that process of social prescribing, putting the person in the driver's seat, building those referral pathways and connections between organizations. What does that add up to? What does that mean? And also some of the more novel social determinants of health. So one of the things that we have really focused on is social isolation and community connectedness. So for example, a great report to look at is one from our work with the Alliance for Healthier Communities that was issued in 2020. It's called RX Community, so like prescription community. So if you Google the RX Community report, we found participants reported a 49% reduction in feelings of loneliness after participating in the program. Even though they were referred to a range of different kinds of activities, that was something that was quite consistent across the program. We also saw that healthcare providers increasingly saw this as part of their scope of practice. So even those who were pretty skeptical at the beginning, once they started trying it, they liked it, they saw that it worked, they could see it fitting into their scope. And so over time, over the period of less than a year, we saw increasing buy-in up to, upwards of, I forget what it was, an 80% or more of people seeing, yeah, this really works for me. So those are the kinds of pieces of evidence that are important to us. There's also some good evidence out of the Guelph work. And so I'll try and see if I can look one up and send it to you, because they have been working with an academic team all the way along. And so have some detailed evaluation work, even though they went through COVID and there were some hiccups in how the program was implemented. They've got data about what the experience was like for people and what the outcomes were like for people when it comes to food in particular. So that's one that I just don't have it at the top of my fingertips, but I will share it with you so you can start to see some of those results. And I'll just mention one other thing, which is that I'm about to embark on a program around developing indicators that are super simple and easy for small organizations to collect and use, so that we can get more of those data and share them and aggregate and help people learn. Because often when we think about evaluation, it gets overly complex too fast, and we can't keep up as community organizations with the demands. So that's a project that, I'm hoping that by this fall, we'll be able to have a set of a few really simple like proxy indicators that help us understand how these are working, and that is something that you might be able to like plug and play into your own practices.
Great. So Josh has raised his hand, and I just want to, as we've had people rolling in, just one final reminder, if you're just joining in and tuned in and have been listening in English, please
vous avez écouté vous voulez écouter en anglais, choisissez dans l'icône du globe en bas.
And likewise, if you're French speaking, choose the French option and you mute the original audio. And thanks, Kate. We have quite a diverse group. We wanted to open this wide up. We have practitioners who have looked at some of those models, have built their own model, and are kind of just exploring it as they're implementing. So I think, this seems like a really timely conversation to be having around different approaches are being taken about indicators and measurement, and how we can be learning and adding to this field conversation, and maybe feeding into that process you've just outlined. Sounds like really exciting. So over to you, Josh, your question or comment.
Yeah, thanks, Jen. And hey, Kate, I'm going to pull a question or like a thread.
Juste sortir une question d'une discussion que nous avons déjà eue.
Sharing a bit of her time with a group of us in Newfoundland and Labrador who are kicking this idea around. It was recommended in our province's health accord recently. So some of us are working on what it could look like. One thing I wanted to surface from that conversation I think might be interesting for this group and dive in on is just how to make this work in the context of folks not having any attachment to primary care providers. So like in our province, probably, I don't know, I forget what the number is, Heidi, but it's a lot. A very significant number of people don't have a physician. And we're actually moving the province in general to like a team-based care model where attachment to a family doctor wouldn't be really the thing. You'd be attached to a team anyhow. But right now we're kind of in the middle, right? A lot of people just don't have any attachment at all. So one of the things that we are thinking about, and maybe I figured this might be useful for folks in the colleges to think about, like to run a social prescribing program for folks who are interacting with the healthcare system in that kind of more ad hoc way, like through walk-ins or things like that. Any thoughts?
Yeah, so thanks for raising this. It absolutely doesn't have to come through primary care, and it actually doesn't even need to come through healthcare. Anybody could, theoretically, in your design of social prescribing, anybody could be a social prescriber. You could self-refer. You could refer from a community agency. You could refer in an informal way. In some countries, in the UK, for example, they have trained people to do what they call sentinel surveillance in connected communities, which really means like you could be a hairdresser who's trained to pick up on the signs that somebody needs support. You could be delivering the mail and have a relationship with people. So you could have any number of different kind of social positions and do this work. So it really doesn't have to be located in healthcare. We're talking about using people who work in employment counseling and support as maybe the primary window into social prescribing. And either they can do some direct referrals or they can help, connect people to somebody who can do the referral. So maybe they're going to connect you to the telephone hotline to talk to a dietitian who can talk you through if you need to do, if your funder needs you to do a very specific type of dietary assessment, for example. There are lots of different ways you can think about who can be a social prescriber and what the pathway looks like. That was just one example there that I shared. And it is important to try to be creative depending on what your context is, because really a lot of this is about also demedicalizing. So we don't want to send people to the healthcare system if we don't have to. It's only if they're there in a way that's sort of inappropriate or not helpful to meeting their health needs that you want to divert them to something that's more upstream, more appropriate, probably more affordable, and so on. It is really important to recognize that this should be something that's able to come from many different places.
Mm-hmm. But I do think, maybe there's a tension there, because I think often an understanding of the social determinants of health is not robust. It is not clearly landing in anybody's responsibility from, as you had mentioned at the beginning, we don't really have a full health system approach. We have a healthcare system with additional sectors patching on. So I think this is a real question and tension as something to work through.
Yeah, and that's one of the reasons why we use the term social prescribing, even though lots of people, especially on the community side, don't love it. It's a way to kind of make asset-based community development that helps address structural and social determinants of health meaningful to people on the healthcare side, but also to the general public. If I talk about social prescribing on the radio, for example, I always get a call from saying like, I need this for my mom, I need this for my neighbor, I need this for myself. People just get it. And so even though, in the future, we might have a more appropriate term, this is the one that makes sense for people and that people can understand and get behind. And so strategically, it's really important as the most inclusive term we've got.
Mm-hmm. So invite anybody else. There's a question from Marin in the chat, talking a bit more about, or asking a question around developing indicators that apply across organizations, and asking if you could share a bit more about how you're working on that, what your process is, and I guess where you're headed, because you've given us some.
So this project hasn't started yet, so I really can't say. I wish I could, but I'll try to keep you posted. But the idea is we'll be, very likely operating within our CISP networks. So we are already connected in with, policymakers, practitioners, people, participants, and decision makers. We pay and support people from equity deserving populations to be there, either as individuals or as organizations. So that network will provide a lot of the sort of feedback mechanisms. And then I'm an academic, so I can rely on some of the academics around some of the details around around indicator development, and then take it to the practitioners and the practice group to say, does this make sense? Or would you actually use this? Would you use it in decision making? Would it help your learning? Could you even collect it? Some of those really pragmatic questions. But if something you're interested in being involved with or learning more about, send me an email, let me know. Because like I said, it's really early days right now. And it's something that, it's something that won't end in the fall. We'll just have sort of a first iteration at that point, and we'll keep learning and developing over ideally a long period of time as we grow this work.
And I didn't give the context of Maren is, one of our funder core partners with the Maple Leaf Center for Action on Food Security, or Maple Leaf Center for Food Security. And I think this has been, their framework was one that the 3 teams who are actively prototyping and implementing food prescribing are exploring how they can best adapt and use, and what kind of impact measures they can strive for, and what information that's going to give them to demonstrate their impact, and then also their learning and understanding. So
I need to talk to you, Maren, and to these 3 groups to learn what you've learned, because you're already thinking about this, and it would be great to have your input as we develop this. The idea is we really want to hear from people who are trying it out and keep things really straightforward and simple, which is actually very rare and hard to do, but we're going to do our best to come up with something that is that's workable.
I really appreciate it, Kate. I won't lead folks down the evaluation rabbit hole, but I will definitely follow up. It's such a difficult balance to find, particularly when you're looking at diverse interventions, diverse populations. So anyway,
yes,
I'd love to learn more about what you're doing.
Yeah, I'll just say that the one thing I will say is that we are likely to rely heavily on patient-reported experience and outcome measures, because some of the other stuff will take a lot longer to see an impact and to really understand the impacts. But if we're able to do very simple process indicators and outcome indicators that come from people who are involved, that would be a really good start.
I'd really love to invite any of the teams who are deep in this, and also Mark Cabaj, our developmental evaluators, on the call too. But I'd really love to hear from Team Saskatchewan, or the Black Creek Community Health Center, the Toronto team, or oh my gosh, I'm going to blank, the Montreal team, the CS Centre Sud, if they would like to chime in and just sort of share a bit of a context of where you're at with your program, and where you're at. If this is resonating for you, or you're like, okay, we have the measures, we've solved your problems, just come to us.
Yes, please.
Yeah.
And I have some questions for you too. After you've shared all yours, I'll have some for you.
Yeah. So Shannon, sorry, I have a teeny screen. My New Year's resolution was to get a second monitor. I've not fulfilled my resolution to myself. So I'm sorry if I'm missing hands up, but Shannon, would you like to jump into the conversation?
Yeah, thanks. And thanks, Kate, for giving that that overview, and kind of like, for me, like a structure to kind of like overarching structure to look at these programs within. I don't have all the answers, but I'm learning lots as we move forward. So the program here, we're working on screening for people, happens in hospital. So they either are inpatients or outpatients. And then they are prescribed a bag of fresh fruit and vegetables to pick up each week. So it's for folks that are dealing with malnutrition and food insecurity. But more, I have a question than answers. I'm curious, yep, Kate, if you can comment on, have you seen any programs work really well around finding ways to include folks in these like social prescribing channels that don't have a phone, so that there isn't a way to follow up with, and then also in rural areas?
Yeah. Okay. So great question. I'm not sure that I can speak to not having a phone, although I'm sure there are interventions doing this. I just can't think off the top of my head. Definitely, especially within that RX community report, you can see some great examples of people doing the work of social prescribing more generally, not always food, but sometimes food, in rural and remote communities. So, and some of them are very culturally targeted. So, a minority Francophone community in remote Northern Ontario setting, for example, or agricultural communities in the southwest of Ontario. So there are some good examples in rural settings. Often they're very focused on transportation. as the number one thing that they need to provide as a way to connect people to supports and services. And again, volunteering is a big part of it. It's already part of the culture in many communities. There's a lot of mutual aid and a lot of strengths in caring for one another. So there's a lot of volunteering and transportation. Those are the things that really tend to stand out. When it comes to people not having access to phones or having terrible internet access and connectivity and all that stuff, we do tend to, especially we saw this during COVID, that people did a lot of more household visits. They sent things by mail and delivery services, lots of household drop-offs and those kinds of things. But they also really focused on digital equity and tried to make sure that people did have access to phones. So street involved youth in Kingston were issued phones. That were, and people scrambled to find the funds for that through various sources wherever they could. So partnering with TELUS, partnering with various partners. It's another one of those sort of community type things that needs to be considered within healthcare budgets. So that we just say, part of the cost of doing business here is making sure everybody has a phone or has some good transportation or some of those like basic infrastructural things that would enable and support the work. So let me look into that, Shannon, in terms of some of the specific examples of where they're doing that, and I'll send it to the Nourish team because I know they're out there. I can't list all of them off the top of my head. I hope that helps.
Yeah, that's great. Thanks, Kate. That did help. And just also kind of brought up, this idea of, I guess when I think of social prescribing too, I'm kind of thinking of, like multiple community organizations that are all working together. And it would just be so neat if there was a community organization already working on digital equity, like in our communities, and then, right, you can partner with them.
Yeah, that's right. And they may not be happening locally, but they're probably happening provincially in most provinces. And so, yeah, including them in your scope of what constitutes social prescribing and what the community of practice looks like is a fantastic idea. And I think also surfacing, again, when we're evaluating and learning, surfacing some of those challenges is really important so that we can say to funders and decision makers, look, this is all fantastic, but it doesn't work without a phone or it doesn't work without internet. Then we can, again, speak to some of those fundamentals that allow us to have access to food in a healthy way. And those fundamentals aren't just income, but there are some of these other infrastructural supports and sometimes very basic, and the same story that we've been telling around a lot of other issues in rural communities for a long time, but this will be our new data that shows this, again, how important it is. I really can't stress enough how important it is to tell health systems and decision makers how impactful the work is and how needed it is in these other spheres to expand their idea of what a health system really is.
Yeah, I feel like that digital equity piece probably is not on the radar. It's got maybe connectivity for business or for people who want to work remotely or those kind of things. But if that is a piece of the healthcare service delivery scope and need to deliver on that, I think that's... Yeah,
I think it grew because of COVID and virtual care, but now many provinces are pulling back from virtual care. And so there's a risk again that'll be defunded. So part of our work is to not lose the gains that we've made.
Roxanne has a question, and also Josh has one in the chat that he put in, which maybe kind of follows on the last point you were making. Maybe so I'll put that to you and then go to you, Roxanne. So I guess his question is around food prescribing outside of the market economy. For example, in Newfoundland, interest in possible prescribing access and quotes for hunted and gathered foods.
So I mean, there are some fantastic examples already happening in Indigenous communities, First Nations, Inuit, and Métis communities, and I think that they don't typically call that social prescribing, right? It might be culture as medicine, land-based learning and so on. But we're actually working really closely in a bit of a parallel process as part of CISP with the Indigenous health leadership at the Canadian Red Cross, who are dialed into a lot of communities, Indigenous communities across the country on developing Indigenous-led, by and for Indigenous people approaches to social prescribing under, many potential names. But there's so much overlap and everybody sees tons of alignment and there's a lot of goodwill. So yes, this does happen. As you said, it happens in traditional communities, but it also happens in other communities. So we have a great example of a guy in rural Ontario in a very small town where people tended to go to retire. And what often happens is people retire in good health, but then within a few years, one spouse becomes sick or even dies. And then there's a person in the new community who doesn't have strong connections there, who's at risk of poor health. So that's what happened with this person. He became very disconnected and very ill, and was on a number of different medications. And he was prescribed through the social prescribing process a fishing buddy. And it had a remarkable impact on his well-being. He got a fishing rod for like $20 and a fishing buddy to go out with. And it really transformed his experience. And he eventually went off his medications, and just had somebody to get to know and to look forward to. So sometimes these interventions can be very tiny. And that act of fishing and being out on the land and being with another human being was transformative for his experience. So I think that, yes, there are lots of ones. And of course, food and food growing is one that's very common for people to be prescribed to and connected to gardening, and that can happen in all sorts of different environments. And some of you are doing this, right? Like I think I saw Phoebe from Black Creek, and they're doing like container gardening in an urban setting. There's lots of different ways that we can do this. They don't all have to be huge, but they can be really impactful and transformative. And most of us have that experience, right, of having done something small like that made a big difference in our lives.
Roxanne, I can't see you you had your hand up. Do you want to ask your question or jump into the conversation?
Yes, sure. Very interesting. This is actually, I recently, just before Christmas, I submitted a proposal. I didn't call it social prescribing, but that's exactly what it was.
Yep.
And it's basically, so in Labrador, where I live, the cost of food and cost of healthy food is so it's out of reach almost for most people, especially those who are at the most at risk, especially with health. They have a whole lot of different things. So there's, as an Indigenous community as well, we believe that connection to nature, getting out in nature, doing things and eating healthy, and would make a big difference in people's outcomes when it comes to healthy outcomes. And so we pitched an idea and a project to, basically allow those, so many people in each community access to, whether that's a voucher system, I'm not sure how that would all work out, but basically being able to afford healthier foods to meet their health needs, and tracking that to show that over a year to 2 years there would be a decrease in the need for medical attention or traditional medicine anyway. So I'm just wondering if, and I was actually going to go to Josh and Heidi, who I always go to, and when I have projects like this in mind. But is this something that your program would be able to assist with? Especially, I'm thinking more about making things simple when it comes to tracking and evaluating these types of programs.
Yeah, so I love it. I love it so much. And it's okay if we call it anything we want to call it. We don't have to call it social prescribing. So yes, I think it's great. And it is the kind of thing that we want to be supporting. We're still growing as an organization, so we do have some capacity limits, but that's where we're headed. And so we're funded under the Healthy Canadians and Communities Fund by the Public Health Agency of Canada, but we also have some private funders that are starting to find us and wanting to support different things, different components of what we do. And before too long, we'll be eligible for implementation funding. And that's where we're hoping the rubber will really hit the road, and we'll be able to provide either funding or hands-on supports to people like you, so that we're consulting and giving the services that you need to make sure we're doing this well. And so we're trying to set up for that by making sure, okay, we've got the tools that you need, we've got screening things that you might want, or indicator tools, and some of those things. So yeah, we should have a follow-up conversation to see if we can't help right now, we will definitely be able to help in the future. And probably sometimes it's even just that conversation that's reassuring that, yeah, you're on the right track and this is looking awesome, and sometimes that's enough to keep you going in the work. So that's where we are in our model right now. But so keep an eye out, and more resources will be available over time if we can keep up with the demand.
So I'm curious, Black Creek Community Health Center or Team Montreal, I want to put you on the spot a bit, I guess, to jump into this conversation and bring in kind of where you're at, or any questions that you have for Kate, or what's resonating, or other issues, because I think she's raised a number of things that I know have been some challenges for you, and I don't want to name them. I'd rather you name them. or where you see success is happening. Or maybe Kate, you have some questions for the group.
I just wanted to jump in before you do to answer Annie's question on the chat say, yes, there is French documentation. Both the prescription community report and any reports that are produced by the Canadian Institute for Social Prescribing are in English and French. So if you go to socialprescribing.ca, which I'll put into the chat, there is a French version of that website, and any materials that we produce are available there. And like I said, the other one that was through the Alliance for Healthier Communities, our earlier project that we did, is also available in both languages.
Thank you. And I just want to say that we are doing like a card that people can come eat for free in our cafeteria. And now I have to do the evaluation part. So that's where it goes. It's hard for me to know what to ask. So that's why this part was really interesting for me, because I really don't know what question to ask. And there's a lot of, I don't have a lot of time, so it really has to be helpful so we can show the government that it's something we need. So maybe if you have more information.
At this point, we're going to be asking about mostly process indicators, like how did you get here? How did you find out about us? And then ask about, was this a good experience for you? Like really, really simple stuff. Would you do this again? Do you think this might have a long-term impact? Like some of those things for the participants and also the practitioners involved. That's sort of the stage we're at now, and that's okay. It was the self-report about your experience and your outcomes. So something really, really simple would be my recommendation. And then you'll also be able to track the concrete stuff around how much food you were providing and all those other sort of more process pieces.
Because I was reading the tool that Nourish gave me from Maple Leaf, and it's really complicated. It's a lot of questions, and it's not really easy to know how to analyze that. So, and it has to go, it's more about analyzing food insecurity, but I think it's too big for just my little project.
Yeah. So again, that's where I think really carefully about the outcomes that matter to you. And you're going to pick a small number. Is the outcome that people want to do this again, or that people see that there's promise in this kind of work and they want to keep expanding it? Maybe that's what you want to focus on. And then later, it's the more complex interventions that the research shows are going to move the needle more on food insecurity. So we're not likely to see an output related to food insecurity from a single intervention. So maybe that's not what we need to be asking at this stage, but maybe there are some proxy indicators that can help when we start aggregating a bunch of these different small interventions together. So I would say just think really carefully about what are some of the short-term outputs and outcomes that you think matter and the experiences that people are having. And that's where we are. That's where we are in the stage of this type of work, and that's okay. That's what we can be communicating. But ideally, if from your perspective it's going well, and it seems that participants and providers agree, that's the story you want to be telling, right? This is something people see that is worth investing in. Here are some indicators that we're on the good track.
I'd love to stay here for a bit longer and go deeper, because I think there's some interesting assumptions we have about this. So I'd be really curious what others are thinking, because one of the principles we're seeking in our evaluation, and it's for demonstrating impact, but also learning, is data and stories. If you just have data without a story, you're missing part of the product. If you just have the story without the hard numbers, you have different kinds of evidence. So I'm really curious, because I think a lot of times we knee-jerk going to a survey. We need to talk to as many people everyone who was touched by this program to really understand its impact. And I wonder whether having some mixed methods might be a way, or I'd be curious, Kate and others, about, as you just mentioned that word, proxy indicators. Are there ways to tell about that pathway and to learn from it without having the ability, the time, as you've mentioned, Annie, and maybe the dollars, or there probably are other barriers that we could surface. It'd be great to hear about, might be related to privacy and information, just the actual logistics, doing this on top of everybody else's workload. And then I think the burden on patients or clients or other users, they're like, stop surveying me. So I think we have a number of challenges that are how we kind of directionally set the course and use the right methods that fit the purpose and the outcome. So I'd I'd be curious, Kate or others, I'd like to spend a few minutes.
I would love to hear more about your challenges and while you're thinking about this, or like ways that you are doing innovative, cool stuff. The one thing I'll say is that, a big part of the ethos of social prescribing is shifting from what's the matter to what matters. So keep that in mind with evaluation. What matters? What really matters to you and to the people involved and to the people who might continue supporting this work? Hone in on that, keep it as simple as feasible. And then when you have capacity, you can do more. But knowing that not everybody has that same capacity, is there a minimum viable set of indicators? And unfortunately, I don't have that answer. We haven't started that yet. But that's what we're going to be, the project we're going to be embarking on, is trying to help figure out some of that out. And so would love to hear from you about what that looks like for you, and to support you in thinking through, well, how do I actually measure that in a way that's feasible? Is a survey the right way to go? Do I talk to people? Do I make sure it's just part of the electronic medical record? And all of those are annoying for people who are participating in them. But if we reframe evaluation as learning, it's helpful, right? If you say, this helps our learning about this project. What are we learning? What do we need to learn? What do we need to know? And the purpose of that learning is to improve and change and tell our stories. That's easier to get our heads around and to focus on what matters. So what's a meaningful measure? That should drive really where you go, and then the methodology can sort of follow your priorities in that case.
But the government wants what? Like, if we just tell stories, maybe it's not gonna give us money,
No, but you can still focus on indicators that are meaningful and matter. So it wouldn't all be anecdotal. You're going to collect data, right? But you can do it in more passive ways, for example, and maybe focus a bit more on administrative data sets that already exist and that kind of thing, rather than always collecting primary data. There are ways we can get creative about thinking about how to collect and use the data in a way that meets those government needs, but also meets your needs.
And Annie, and then I'll go to you, Anika. I think it's so interesting. I had the opportunity with Haley to get a tour and to see some of the Carte Solidaire in action. And I think a number of things you're observing are not they're at the system level or the healthcare provider level, around seeing changes in how people are accessing their appointments and showing up on time. And I wonder if Kate or any of you would validate that, if that's something I think also very interesting at an administrative level to learn more about where are you seeing these, costs or feedback loops back into how the system is being efficient and being well used. So
those are my favorite ones, because I'm interested at that systems level and I want to show people like, this is going to make your life easier and better and help people, right? So yeah, I would love to hear more about those process indicators for people who are doing the work.
So Annie, do you have any insights there, or what is your first thought on
For
that?
now, it's just the people we talked to that said that, it's not an indicator yet, but we have like full story that tells us that it's really a tool for them. So they see more often their patient, because it's usually homeless and with drugs, drug user. So for them, it's easier to see them because they're gonna come to ask for the card to come to eat. So it's just a story. So I want to make this is a question we will ask them for sure.
Mm-hmm.
Yeah, and maybe they already have a bit of tracking that happens through their work. Like if they have performance management software or something where they can look at, well, how much time was I spending with the client before and how much time am I spending with them now? And some of those things might be in their existing business improvement systems if they have such a thing. So, focusing a bit more on the providers and their experiences and their perceptions, that might be okay at this stage, even though, of course, we want to be including participants and their voices. It might be okay to spend more time with the providers, get them to do a big, long survey, but keeping it straightforward for them, and then do something that's a little more targeted, like a focus group or something that's easier and more conversational. Maybe you just sit down with some of the participants one day and chat with them, and that counts as your focus group, and that's your participant input, right? So we can think about what's feasible from the different types of participants that you have.
Renika, you're next, and then I saw another hand go up. I think it was Stephanie, so go with Renika first.
Thank you. And thank you, Kate. You kind of just went into what I was going to talk about in terms of focus groups. That's something that Black Creek did. I'm with Black Creek and working with Phoebe along as well, who introduced me to Nourish. And one thing we did with our focus group is figure out what exactly our community needs. So we had a little retreat with our community health ambassadors, and we asked some questions in regards to what our community needs, because they're like the branches in our community. And through focus groups, through some flip charts and answering some questions, they had discussion and dialogue in regards to food security, which is kind of a major one. Our Black Creek in the Jane and Finch community, a lot of our community is our Black community, and food deserts, low access to healthy foods was something that kind of prompted us to get into food prescriptions for this project. And we thought that just connecting with them and just figuring out what's the best ways to do food prescriptions in a social aspect. So one thing that we're trying to roll out for the next month is actually cooking workshops that will be done on site. So families can come, learn, have recipes to take away, also have some food baskets that they can practice and make those meals preparations as a family. And it can be a sustainable thing so that they can actually learn to cook nutritional meals, learn to get accessible foods and where best to get accessible foods, cooking on a budget, and those kind of things. But one question I do have, because I do connect with some of our clients who are homebound, who won't be able to access and come to the center, is if you, Kate, have any suggestions, or anyone on this call, as to ways that we can access people who are from home, not necessarily tech savvy to be on a Zoom call, but would love to receive food prescriptions and actually need to receive food prescriptions as they're homebound.
I'll look to the group first, I think, to see if they have suggestions on that one, and then I'll weigh in.
Thank you.
Some of you might be doing this.
It's a tough one.
Yeah. I mean, I think it partly depends on your resources. Like if you have the capacity to do home visits and deliveries and drop-offs, that's what you need to do.
Yeah.
And maybe, you know, a good way to start would be to start with people who live in buildings where there's, you know, a significant number of folks who are going through something similar. And then you can develop a local capacity to have volunteers or community health workers deliver programming and services in the building, for example,
Okay.
right? So you can think in those kinds of ways if you have the resources to do that.
Yeah.
And then there are some other creative ways to do that too. And one thing that I was involved with before was a development of a local food buyers club where communities living in social housing in Toronto got together to negotiate better access to healthy food as a food buying club, as a collective. So that's the kind of thing you could think about brokering a relationship around in, you know, where there's sort of a critical mass of people who can collectively drive prices down by creating a whole new way of approaching it. So there are some really creative ways to get at doing food prescribing in these places, but they do require a little bit of runway. Like you need a little bit of thinking, you need partnership, you need a bit of resourcing, but there are some pretty creative and interesting ways to do that collective food procurement. And I believe it should still be available through Toronto Public Health, some innovative food procurement supports. So something worth looking into through their food strategy work that maybe you might be able to partner with and find some other opportunities.
Yeah, okay, thank you.
Okay.
Stephanie, hello, are you there?
I'm here. Thank you very much, Jen. Hello, everyone. Kate, nice to see you, and thank you for your presentation and your information. We are just, I would say, still in our early launch period for our food prescribing program, which is called Apple a Day, where Saskatchewan Health Authority and Shannon, who spoke earlier, is part of this team. When I think about when I think about food prescribing, some of the early lessons learned, I'd like to share. They might be helpful to others, but the first one that really struck me, which is a bit of a hard lesson, is just because you built it doesn't mean they will come. So I think for people to recognize, I think that was our biggest lesson learned thus far. Even though we had this program and tons of excitement around it, and felt like we would be, you know, full. We'd have 100 participants in a week. That actually wasn't a reality. And I think for us, the lessons learned around that is, number one, do not underestimate the importance of transportation. What we have learned is that is a major challenge for folks. And some of our participants tell us the stories of their, I would say, perilous trips and how they managed to get to us to pick up a food bag. So I think that was something that surprised us, and mostly because we were building our program based on lessons learned from other programs where people did actively go and access the resource. So we were anticipating the same, but we have a healthcare model where you are enrolled at the hospital level. And I think another piece there that's important, or at least I'm really reflecting a lot upon, is the importance of establishing trust at that healthcare provider, at that interaction where people are introduced to the program. So that it's a really important relationship, and I think we have to be really mindful of that. One of the things that we've been contemplating, and I'd be interested in anyone's feedback, is we're a fruit and vegetable bag program. And our thought was, are we missing a really valuable opportunity by not including a protein source in those bags? Some sort of shelf stable that maybe expensive items that folks might have challenges affording, and that may increase the desirability of coming to get that bag as we're exploring models of getting the bag to people. So I think that's really where we're going now. And a couple of suggestions, we've linked in and are in conversations with Meals on Wheels providers. They're often going to the neighborhoods where the folks on our food program are also going to, and because we're part of the health authority, linking with volunteer services to look at some opportunities there. So just a couple questions in there, and a bit of my my musings aloud. So thank you.
Thanks, Stephanie. I mean, those are super important insights, and I'm glad that you're sharing them around the importance of building trust and, again, transportation and basic infrastructure as something that's required to underpin this work, and just how precarious all of it can be when we don't have some of that. I think that's super important for us to keep in mind as we continue doing this work going forward. And I'll open it up to the group around those things, and also around the question of what needs to be included in the food prescription, what types of food are going to be of interest to people and meaningful to all the different stakeholders involved.
So just to give some kind of context, like we do have two separate social prescribing pilots going on. So one of them is just regular fruits and vegetable bag, which is doing well. That is actually getting delivered to participants' homes on a bi-monthly basis. So that is helping with the access issue, especially in the winter now that it's snowy. What Renika was mentioning is she is also part of the Black social prescribing pilot, where in conjunction with the other things, Kate, I guess you know about this pilot with the other CHCs, but that is more socially based. So like tickets to like theater and things like that. But because of this Nourish grant, we're also able to bring a food aspect into it. And so in the past, we had done food hampers that were received really well because they were culturally appropriate food items. So we had like a Caribbean bag that had like, you know, the correct spicing and saltfish and like ackee and actual things that they people could use and enjoy, and things that were expensive. And then same with also like a Latin bag that had spices. So I think Renika, you can speak to this as well, as part of what you're planning to put in your hampers or your food boxes are also culturally appropriate spices, foods, things like that, in addition to the fruits and vegetables, to really target it for the population that is here.
Yes, and I did forget that part of our programming is also the delivery aspect. And I also do have experience delivering. I've my prior role was actually doing deliveries myself. But it was just in terms of some in particular who I just wanted to kind of switch it up and see if there were other things that people were doing other than deliveries that could also speak to and engage in a different way those who are homebound and cannot leave their home at all.
I'll just say one thing that I really love about this, and that is, I mean, in addition to being culturally appropriate, that really speaks to the importance of belonging, and that you feel heard, seen, and prioritized when the food box is meaningful to you, and it reconnects you with your culture, which we know is also a significant determinant of health, and you feel valued in terms of all the cultural associations you have with food and well-being. So I totally love that. And there probably are some really other good examples out there about how you're reaching people who are homebound.
What I also love too is, Renika, they've also thought about, using folks from the community. So like we're looking to, use honorariums to maybe help facilitate those deliveries for volunteers of the community. And also you were using local chefs, right? You're using community chefs to help develop recipes and things like that as well.
Yes, what I'm finding, as Phoebe did mention, I kind of forgot, what I'm finding for the Black social prescribing is everything is community. So everything is communal, working together, coming together. Food is like number one in terms of bringing people together. And I think that goes across from many different cultures. So I think in terms of food prescriptions as a start, which we haven't launched as of yet, this is going to take off more in February, is a perfect start to kind of connect people together. And I love, Kate, I actually wrote it down. It's not what matters, what's the matter with you, it what matters to you. And that's like, yeah, that's gold right there. So I'm borrowing that.
Yes, please do. And never underestimate the power of intergenerational work on some of this too, right? If you can get some young people who are motivated and capable of doing deliveries, and then older people who are capable of mentoring and providing a little space for young people to connect with their culture and with the knowledge that's held by elders and so on, there's some really, really neat stuff you can do. And sometimes just from a very pragmatic perspective, young people need volunteer hours to do things. So you can consider that as something that could work.
I'm wondering, I mean, because Stephanie, you have a completely opposite issue to ours. Like we're a very condensed area, and we have a ton of people who want to be involved in the program. So, but I'm wondering if maybe there's like select drop-off spaces that might be closer to each place where people could go and pick up for other people, like instead of just one, but maybe you kind of spread it out more. I don't know.
Phoebe, thank you for that comment. We're absolutely considering all those things. There's no real clusters to the people in our program. Like it's quite wide distribution, so it's going to take some unique planning, but I think we have a solve. Like we are planning to move to a transportation distribution model. One of our other unique challenges is one of our communities that we're targeting with this program is in very northern Saskatchewan, small community. And what we're finding is that the health center there is maybe not the greatest source of need. And it's in fact, people access care there from a location about 80 to 100 kilometers away. And so we have a little cluster building there. So Shannon and I are working on some ways for outreach there, like how do we get and we've talked about, maybe it's not a weekly food bag, maybe it's a monthly food box. Because that's something that we can maybe afford, that kind of travel back and forth, like, from one of our members. And again, the cost of inputs are increasing. So we're finding we have less volunteers wanting to do distribution because the cost of gas has increased so much. So we're looking at some other, and also, I'm just thinking about this, Shannon, and you can expand if you like, we're finding that there may be opportunity for one person in that community to take back, like do that transport, or maybe them sharing it. So becoming a little community to come collect and go back. Shannon, am I reflecting those discussions correctly?
Yeah, you are. And I would just say, like, each of our communities, we've worked with someone in each of the communities. There's 3 of them who like would be kind of our local expert. And so actually each of them are set up differently from the start. So the one that is the northern area does already have like kind of 3 hubs where they're going to drop off food and it can be picked up. And yes, we are thinking about potentially having someone who's participating in the program, like covering their mileage and having them do the delivery. My only concern is that then if one person isn't able to make the drive, then, 10 people don't get food. And so, so there's lots to like navigate within there.
What's coming up? Oh, sorry, go ahead, Kate.
I was just, one thing that I think might be important here too is to expand our idea of who's in the community of social prescribing to, in some cases, include the private sector here, right? If there are deliveries happening to these communities, maybe it's Amazon, maybe it's a trucking company, maybe it's gas, right? All the different things that are already happening. This could be an easy win, corporate philanthropy piece of partnership. So, I think it's worth having some conversations about what already happens, what's already reaching people. We know that Amazon penetrates into the tiniest communities. How do they do that? Right? So they're maybe not the best example because I don't know about their willingness to partner, but there might be some more locally based or regional transport companies and so on that are already making some of these trips and might consider a partnership. So think creatively about who your partners might be in this case and how you could find some shared benefit.
And on that sort of hub spoke model, I mean, Kate, you will have more, I forget the term, but at the core of the Good Food Box in Toronto, one of the major programs of Food Share Toronto, and, a principle of organizing comes from, my understanding is one of its origins is in a Japanese organizing where you have hubs of 10, where one person knows 10 people, they can count them on their fingers. And that is how some of the early cooperative food buying happened in Japan, led by women who are connecting in with their social networks. And it's been part of the Barack Obama, campaigning. I just think it's very compelling and a really simple way. Like it's a beautiful way to talk about who do you know in your community and who can you be supporting and helping. I know all of these things are probably extra on top of some of the major challenges we're facing in a modern society, pandemic, isolation, rising inflation, all these other things, but there's a lot of hope and I think possibility there to dream a little bigger if we're in all the period of turmoil that we're in, that maybe there's something else that's going to be binding our communities together. But it sounds also Pollyanna and up in the sky. How would we ever make this happen? But I think that's where we're excited, where you guys are out in the field, experiencing, learning, and really testing some of these things out so we can be taking a lot of inspiration and hope from your struggles.
There's a lot of goodwill around it. Like, be reassured that decision makers love hearing your stories and want to hear more of it and are really interested in this. So, if we can help to share your data, your evaluations, your needs, we'd really love to do that. And maybe we can help connect you with researchers and evaluators if that's helpful. That's what we really want to be able to do, is to be in a position to support you and connect you to other people doing the good work. And it's not going back in the bottle. There's interest, and we want to continue maintaining that and growing it.
So our group's got a little smaller. I guess like an hour and a half is a hard time for people to be away. So thank you for staying. This has been such a rich conversation. We have a few last minutes. So if you haven't spoken, would invite you to raise your hand or just unmute yourself and jump in if there's any thoughts. Or
if
Kate,
there's any,
you haven't had any chance to ask questions to us. So.
Yeah, I mean, if there's something you need that would support you in your work, what is it? What's a barrier you're facing, a tool you need, a support that would be really helpful? You might not know yet, but if you do, lay it on me.
I don't have a tool or anything. Kate, I'm sorry, but one piece that we will be collecting, because I think it's really valuable and maybe often overlooked, is the value this sort of food prescribing brings to the person who is doing the prescribing. So for us, it's the dietitian team. And so we have a group of clinical dietitians who have, spent their, 20 years of their lives, like identifying malnutrition in the hospital and then sending these folks home to the very communities where they became malnourished. And so to finally have the opportunity to actually provide an intervention that has some meaning, there's high value there for them. It makes them feel like they're doing something, making a difference in people's lives. So I think that's also a valuable outcome that we ought to be sharing.
I could not agree more. And I think at this time when healthcare folks are facing huge stresses, if we can show that this is going to help them in some way, that's going to go a long way.
And there's a growing movement too. Sorry, I might have missed two of the comments. One from Kim, just speaking about some of the other things in the field that are happening. So there's the Market Greens initiative of the Community Food Centers Canada. And I think, Josh, you've had a few comments here. Sorry, I minimized my screen. I missed it around some of the things happening where you're getting connected into other initiatives, shared delivery services writ large that could have a food component. So maybe we can end on a positive note, or any thoughts from anybody else or Kate on kind of like, where do you see this heading? Like what's going to be our pathway? I love that we can't put it back in the bottle. I'm going to steal that or try to remember to use that more often as well. But any thoughts there or any other things people want to add in?
On what I think, where we're headed from here?
Yeah, in terms of the field, because I feel like this is a big question. How can we afford it? How can we afford not to, right? There's like I feel like that's kind of a way to understand this moment.
Yeah, this is what I think one area where your data and your stories really matter, because we want to be able to help funders, decision makers, and practitioners see that this can help with some of their immediate problems. That overburdening of the healthcare system, for example, and it can help with longer term resilience. What we want to be able to tell folks is that the communities that had strong social connectedness and programs fared better during the pandemic and will always fare better in times of shock and uncertainty and disruption. That's true for us individually, and that's true for us as communities. So what can we do to build resilience and be really ready and prepared for other shocks that come along when it's climate change, when it's opioid harm reduction, and so on, all the different challenges that we're facing. So I think we need to be able to tell that story in terms of what does this do to help you with your immediate problem, and how does it help prevent some of that problem even in the medium and longer term. They can't think too long term. We can though. And so being able to have the data that helps us make that case is going to make your lives easier in the long run, because we'll be able to help expand the capacity and the resourcing and the systems in which you do the good work that you do. So you're the icebreakers, and that's hard work. And I'm so grateful to all of you for going and figuring this stuff out. And it's hard and it can be really tiring, and it's just really important. And I'm so thankful. And wherever you are able to share some of that learning, we can help to, like I said, aggregate it and turn it into evidence that's meaningful to different people in different parts of the systems, and to scale it up. So I would say that where it's headed is this is growing. Lots of people are trying it out. We want to make it easier for people, so not everybody is starting from square one. And we want to help existing initiatives connect to some of those core principles of what makes it social prescribing and not just something more transactional. And then, we'll keep telling that story, and I expect more funding and more opportunities to continue to happen. And our goal is that, in the next 5 or 10 years, this is something that's considered mainstream and funded and understood accordingly. So that's where I want to be, and that's where I really do think we can get there in the medium term. And in the short term, we just need to keep telling the stories and sharing our data to help us get there.
I think that's a great note to end on. Kate, thank you so much. Thank you everybody for spending the time, doing the work, being honest and open in these challenges and opportunities you have. Really appreciate everybody. And I think this is a live conversation in our work and how we best support you as the teams in the cohort and support the cross-sector or cross-cohort team learning and where we want to be heading and building up to, the impact across the cohort and being part of that short to medium term wave and collaborating, I think, Kate, with you and others, this is something we really want to keep as an open channel of communication. So your feedback welcome about this conversation, what it brings up, and any ideas where, where Nourish can be helping to host conversations, codify things, develop tools, all the things we're already doing. We're always, wanting to keep that be a live conversation.
And if you want to be involved with other people doing the work, go to socialprescribing.ca and join one of our communities of interest or communities of practice so you can connect and find out what else is going on. We'd really, really welcome you to be there.
Great, thank you. And thank you to our, Peter and Adrian, our interpreters, and my team for helping with the tech support. And so we're ending a few minutes early. Go have a bathroom break before your next meeting.